Okay, so now let me introduce our first speaker for today, Professor Dr. Iman Hakim. So Professor Hakim is the Mel and Enid Zuckerman Endowed Chair in Public Health and Dean of University of Arizona, Mel and Enid Zuckerman College of Public Health. She is internationally recognized for her translational research and works on the role of bioactive food compounds such as green tea and D-limonene in the modulation of oxidative damage and prevention of chronic diseases such as cancer, cardiovascular diseases, and diabetes. And her research focuses on health promotion, dietary interventions, and the role of gene environment and gene nutrition interactions in chronic disease prevention. Prof. Hakim is also the founding director of Global Health Institute and has held various leadership roles, including chairing the accreditation committee for ASPPH. Her work spans large-scale interventions and clinical trials in nutrition, cancer prevention, and gene-environment interaction. Prof. Hakim earns her medical degree in Cairo University, completed her pediatric residency, and holds a PhD degree in child health and nutrition from Isham University, along with an NPH from University of Arizona. She has spoken at national and international conferences and is actively involved in global health partnerships. So now, without further ado, I would like to hand it over to Prof. Hakim to begin with her presentation. Prof. Hakim, the floor is yours.
Thank you very much, and good evening, everyone. I'm really thrilled to be with you tonight to discuss the role of global landscape in non-communicable disease, and then be available to answer any questions. Next, please. Next, yeah. So to get an overview, what is non-communicable diseases? As you might know, these are chronic diseases that take a long time to develop. They have multiple risk factors, so very complex in nature. And that's why a complete cure is rarely achieved. And because they're a result of a combination of factors, these could include genetics, behavior, physiological, as well as environmental factors. They're often associated with older age, but the data show that around 17 million non-communicable disease deaths occur before the age of 70. And unfortunately, of these premature deaths, 86% are estimated to happen in low and middle income countries. Next, please. Next, please. So some of the data to show, as you look to the graph, the blue, different shade of blue represent non-communicable disease, while the different shades of yellow represent other disease like communicable, maternal and child health, nutrition, and so forth. So if you look to the global burden of disease, you can see that the blue area, which is then non-communicable, are taking the majority of the cause. Then it is broken by countries. So you can see the high-income countries have the majority of non-communicable diseases. However, with low-income country, there is still persistence of communicable diseases, in addition to the burden of starting the rise of non-communicable disease, where most of the deaths occur. Next, please. Next. So the global landscape. Looking to the data, you find that the non-communicable disease kill around 41 million people each year. These account to around 74% of all the deaths globally. And of these deaths, 77% are in low and middle income countries. So each year, around 17 million people will die from one of the non-communicable disease before the age of 70. And as I said earlier, 86% of these deaths occur in the low and middle income countries, which is a very big case of disparities across the globe. So the annual deaths from non-communicable disease are actually projected to be around 52 million by the year 2030. And if we think about the major communicable disease, cardiovascular will come on the top with around 17.9 million annually. This is followed by cancer for around 9 and 30 million, then chronic respiratory disease for around 4 million, and then diabetes come which is 2 million, and this include kidney disease death caused by diabetes specifically. So these four groups account for around 80% of all premature non-communicable disease death. So other causes, as you might know, will include dementia, Alzheimer's, arthritis, musculoskeletal disease, and so on. And I put the reference down there. So what are the risk factors? We talked about, we have main four group of disease, and it is a complex factor. So the main one, when we talk about modifiable behavior risk factor, there are some metabolic and also environmental. So the one that we can really intervene with, and a lot of work is being done and need to be done, is a modifiable behavior risk factor. And among those, tobacco come on the top with over 8 million deaths every year. And this includes secondhand smoke as well. Then we have another 8 million deaths annually due to dietary risk combined. And this dietary risk, which we can intervene on, account for around 19% of all of non-communicable deaths. Then we have around 1.7 related to alcohol abuse, as well as around less than 1 million, which happen due to physical inactivity. And what are the metabolic risk factors? And this is where many of the intervention related to accumulation over the years. So high blood pressure, which is hypertension, is our account for 1.3 billion for adults that reach the age range between 30 to 79. This is followed by hyperlipidemia, cholesterol and triglyceride, and so on, overweight and obesity, and then hyperglycemia, which lead to diabetes. And so what are the environmental risk factors then? As we all know, and it has been declared that climate change is a crisis, is actually major public health crisis. So air pollution and the environmental factor are the main risk now, accounting for around 6.7 million deaths globally, and which about 5 of those are due to non-communicable disease. These include, but not limited to, stroke, COPD, and lung cancer. Next, please. So what is the global health agenda, and how everybody know about communicable disease infection since many, many years. However, for NCDs, they are relatively a new priority onto the global health agenda. The UN high-level meeting on NCD takes place in 2011 and 2014, and they focus on the 4x4 approach, which I will explain shortly. In 2018, the third UN high-level meeting formally then recognized and added mental health and air pollution as core component of NCD response, thereby introducing the 5x5 approach. And so as you can see from the graph, 3/4 of all deaths in the world now are coming from NCDs, and every 2 seconds, someone under the age of 70 will die from a non-communicable disease. And that makes the case that investing in non-communicable disease prevention and treatment is very important for the economic growth as well as for our own individual health. Next, please. So what is a 4+4 approach? As we talked earlier, there are 4 main groups of diseases, and there are many modifiable factors. But the 4 main diseases, as we said, cardiovascular, cancer, diabetes, and chronic respiratory diseases. And the 4 main modifiable risk factors were listed or known as tobacco use, alcohol use, unhealthy diet, and physical inactivity. And as I mentioned, in 2018, they added the 5+5 approach, and basically adding mental health and to the main non-communicable disease that include dementia, that also include Alzheimer. And then the main modifiable risk factor, as we talked earlier, now include air pollution. And what this tells us is if we can do something, we can actually work on this modifiable risk factor because all of them are preventable or controllable. Next, please. So what are the challenges? We have some factor behavior, we can act on it. But if you really know behavior, it is very hard to change because behavior come to start very early. And because of the marketing, you just look around, consumption of unhealthy food, tobacco use, harmful use of alcohol are heavily influenced by aggressive promotion. And all of these ad and advertisement in all media, they always target young people. And companies have different way to change the product from one to the other and making appealing. So these behaviors start to build early in age. But also to change behavior, we have to have government action. This is vital because changing behavior is difficult. This can come in the form of policy, like ban tobacco use in areas or restaurants. That can come in taxes, adding extra taxes on tobacco, alcohol, so make it very hard to obtain, being very diligent in food labels so people become educated what they are consuming and so on. And the other challenges is, as we said, for non-communicable diseases, we are talking about the whole cascade of management, which will be prevention, screening, early diagnosis, control, and treatment. So screening and diagnosis, 2/3 of the people have hypertension live in low and middle income countries. But half of the people with hypertension, they are not even aware they have it. The same goes for diabetes. When you do a general screening, you find at least a big percentage of the people showing up have high glucose level and they don't even know it. Access and cost. And this is because in low income countries, 44% of all spending is paid by own people pockets. There is no universal health insurance, or there is no access, no close by clinic. And this is particularly in the case of non-communicable disease because the signs and symptoms of disease are very silent. People can go, as I said, with high blood pressure, high glucose, and they don't even know it. As compared, if you have fever or you have infection, you will run to try to get sick for health. And the main one, if you want to make a measure, and that's what WHO and the UN also are focusing on, is the health system. There is a big intervention to strengthen the health system globally. Then this through incorporation of policies and service, again, for the prevention and control of non-communicable disease to strengthen this health system should be our priority globally. Next, please. So what is the WHO Global Action Plan? And that's a plan that was implemented for prevention and control of NCD between 2013 and 2020. And the report is available online. So the vision was, it is a world free of avoidable burden of disease. And the goal is to reduce the preventable and avoidable burden of morbidity, mortality, and disability due to NCDs by working through a multi-sectoral collaboration, both at the national, regional, and global level. And the overarching principle for this action was to have a life course approach, start early for prevention, empowerment of the people and communities to make behavior change, employed evidence-based strategy, universal health coverage, management of real and perceived conflict of interest, human rights approach, equity-based national action, both at the international cooperation and multi-sectoral action. Next, please. So even with the Sustainable Development Goals, preventing and treating non-communicable disease is part of it because it has benefit far beyond health. So prevention and treatment of NCDs, prime opportunity to investment of people. It is key and impact economic growth, having healthy population, productivity, decrease the missing for work, and so on. So they are at the heart of sustainable development, and they are recognizing this importance in the goal 3.4, which has in its heart to reduce premature death from non-communicable diseases by 2030. But until the latest data show, until 2022, only a handful of countries were on track to meet that target on reducing the early deaths by 2030. Next, please. So what are the voluntary global targets that we are all in public health and globally working in? So the target is to decrease the risk of premature death from cardiovascular cancer, diabetes, and chronic respiratory disease, the four main group, by 25%. And at least a 10% relative reduction in the harmful use of alcohol as appropriate within the context of every nation. 10% relative reduction in the prevalence of insufficient physical activity, like basically try to make people walk as before and being active. 30% relative reduction in the intake of salt and sodium, and 30% relative reduction in the prevalence of current tobacco use in person age 15 and plus. 25% relative reduction, or at least to try to contain the prevalence of raised blood pressure. Halt the rise of diabetes and obesity, and at least 50% of eligible people receive treatment, counseling that include the glucose control to prevent heart attack and strokes, and 80% availability of the affordable basic technologies and essential medicine that will include generic required to treat major NCDs and have that treatment available globally at a generic and affordable cost. Next, please. So leading from the top, now we have the Global Compact on NCDs that was reported or published in 22-23. So the global group of heads of state of government on NCD is an informal and a voluntary initiative and working on NCD prevention and control at the highest level. They are led by Norway and Ghana. So the group launched a global impact on NCD in April of 22 with the goal of saving 50 billion people from dying prematurely by 2030 through focusing on 5 key areas. These are the key areas below, which is reducing deaths from NCDs by implementing cost-effective measures to prevent and control NCDs, integrating NCDs within primary health care and universal health coverage, comprehensive surveillance and monitoring to see how we are doing, protecting people living with NCD during humanitarian emergency so they don't get forgotten like during COVID and the other. The main focus has been on the communicable, and people with chronic disease in some areas have been forgotten or not get the appropriate attention. And then meaningfully engaging people living with NCDs and mental health condition in policy making and programming. And I put the reference down there, and the post reports are available. Next, please. So in summary, non-communicable diseases are a huge challenge affecting individuals, families, and economies locally, nationally, and globally. An important way to control NCD is to focus on reducing risk factors associated with this disease. So prevention, health promotion is actually a great healthcare approach. So effective NCD intervention can be delivered through a primary health care. People listen more when their physician or their primary care tell them about the importance of prevention, the importance of moving, the importance of reducing salt or controlling obesity. It makes a big impact when they hear it from their primary care physician or primary care provider. Even community health workers that are working in rural area will have a great impact on reducing these risk factors. We need to make long-term investment in prevention and better management. And with management, we mean screening, detection, and treatment. And this is critical that to address the cascade that leads to non-manageable, non-communicable disease. And as you see, prevention is the best treatment. At least that's what I believe. So monitoring progress and trends of non-communicable disease and the risk is important for guiding policies and priorities. Next, please. With this, I would like to thank you and for listening, and we will pass it to the next speaker. Thank you very much.
Thank you very much, Prof. Hakim, for the great presentation and sharing. So for the audience, if you have any questions, you can type in the Q&A chat box. Okay, so now let me welcome our next speaker, Professor Emeritus Dato, Dr. Syed Mohamed Aljunid. So a little bit of introduction. Prof. Aljunid is a distinguished public health medicine consultant and professor of public health and community medicine department at the IMU University, Malaysia. With a rich academic background, including a PhD in health economics and financing from the London School of Hygiene and Tropical Medicine, MSPH from the National University of Singapore, and an MD from National University of Malaysia, he has over 30 years of expertise in health policy, economics, and financing, and he has held prominent positions such as founding head of International Center for Case Mix and Clinical Coding at UKM's Faculty of Medicines, and also a senior research fellow at United Nations University International Institute for Global Health. Honored as an emeritus professor in public health by National University of Malaysia in 2022, Prof. Aljunid currently chairs the Technical Working Group on Health Financing at the Ministry of Health Malaysia, and he has consulted for international organizations like WHO and World Bank, and co-chaired the Morbidity Technical Advisory Group for ICD-11 revision. With over 250 publications and 300 presentations globally, Prof. Aljunid's contribution to public health and health economics are widely recognized. So without further ado, I will now hand it over to Prof. Aljunid to begin with his presentation. So please take the lead, Prof.
Thank you so much, Dr. Lin. And let me just give me the outline of what I will present. I will talk about the current challenges in global health, and then I will focus on universal health coverage, and I will talk about the economic burden of NCDs. Much of it has been touched upon by Professor Hakim. And I will talk about the health sector reform, which is being initiated in Malaysia at the moment. And I go into my favorite subject, which is the National Health Financing Scheme, and what are the opportunities for the MPH graduates in the context of the health sector reform in Malaysia and also in other developing countries. Next slide. If you look at globally, all countries in the world are facing with these 5 major challenges. First of all is regarding the effort to achieve and maintain universal health coverage, establishing a sustainable sustainable health financing system, as mentioned by Prof. Hakim, regarding the need of resources, especially to manage non-communicable diseases, efficiency in the use of resources, effective management of chronic diseases, including non-communicable as well as communicable diseases which are chronic in nature. And also we are facing with the aged population in most countries in the world. All these 5 put a lot of pressure on the health system in most countries in the world today. Next slide. Let me focus on universal health coverage, which is one of the target in the Sustainable Development Goal number 3. Universal health coverage ideas was actually started on by Professor Enid from London School of Hygiene, where she actually stated that countries should create a situation where everybody in the country should have access to good quality of care, but this access to the services should not be determined by the income level, their social status, or residency with the place where they stay, other urban or rural area. But this access should only be determined by the needs of healthcare and also their preferences. In 2008, WHO adopted this as one of the important goals that should be tried to be achieved by most countries in the world. Next slide. There are many factors that need to put in place in order for us to achieve universal health coverage and to maintain it. This includes appropriate technology, availability of healthcare facilities, good information system, which can be helpful in making a proper decision making. Of course, we need financial resources. We need health human resource. About 70% of the resources in the healthcare system are spent on health human resource. We need a proper policy And the other important factor is the political support. This is very important. And if we have all this, we should be able to achieve and maintain universal health coverage. Next slide. Next slide, please. However, in many countries, there are a lot of obstacles facing this country's health system. This includes, for example, the emerging and re-emerging of new diseases. We have just come out from the COVID-19 pandemic, which actually engulfed quite a huge amount of resources in most countries. Inadequate information for decision-making, raise in healthcare costs, of course, increasing prevalence of chronic non-communicable diseases, and lack of resources because the inability for the country to set up a sustainable health financing scheme. If you look at the latest report on universal health coverage, which was just published last year by WHO, almost only 42 countries in the world achieved more than 80% or 80 points in the coverage score, which means that if we use this as the benchmark for universal health coverage, which means that only 42 countries has achieved and maintained universal health coverage. Most countries actually achieve below this score, which means that we still have a lot of problem in maintaining, if countries have achieved universal health coverage before, to actually maintain this for a long term. Next slide. Globally, in terms of the health expenditure, the whole country in the world spends about 9.8 trillion US dollar in 2021, which equivalent to 10.3% of the global GDP. And there is an annual increase of about at least 6% every year between 2000 and 2017. If you look at the per capita expenditure, half of the world countries spend less than USD 366, although the average spending, if you combine all the countries, is more than 1,000 US dollar per capita. And 50 countries, which actually consist of 2.7 billion people, spend less than $100 per capita per year. This shows that there's a huge gap in terms of the resources, the availability of resources for countries to spend on healthcare. And many countries try to set up the social insurance program in order to actually mitigate some of these issues in terms of the lack of resource, sustainable health resources. Next slide. This is the one of the issues that are facing universal health coverage, increasing prevalence of non-communicable diseases. We can see that more than half of the loss of output is actually due to cardiovascular diseases. And if you look at the amount of resources that are lost, most of it actually come from upper middle income country, and which engulf 70% of the total loss of output. In terms of the four chronic conditions: diabetes, cardiovascular diseases, respiratory diseases, and cancers, the total amount in low and medium country is equivalent to about 7.28 trillion US dollar. The whole country, the whole world is spending about nearly about 9 billion. If we were to spend 7.2 billion only on these four diseases, we would hardly have any left resources to actually manage other parts of the disease or other conditions that are actually impacting the health of the status of the population. Next slide. What are the strategies to achieve universal health coverage? These are the strategies which was actually proposed by WHO for countries to consider. First of all, since universal health coverage the effort is to provide the resources to cover the poor, so priority should be given to the poor. We need to rely more on the public funding or funding which are actually organized by the government and focusing on the poor. We have to reduce out-of-pocket spending. Higher out-of-pocket spending would be one of the factors that actually reduce the likelihood of achieving and maintaining universal health coverage. And the other important point is proposed by WHO is to develop health system further. What do we mean by this? Next slide. Next, please. Yeah. Among the things that was actually proposed in order to develop the health system further to maintain and achieve universal coverage is to establish a pre-payment system such as social health insurance or some form of health financing system, which is most of the time based on the concept or the framework of social health insurance. the system to be decentralized to ensure that services can be provided and managed effectively at the periphery of the central part of the country. We should encourage stakeholders to work in team, empower community to support health system, and also one of the important aspects is to be able to use effectively data that is available for decision making. Next slide. In Malaysia, in June 2023, the government approved what we call the health white paper. This is actually the plan for the government to reform the health system. There are 4 pillars which was listed in this health white paper. The 4 pillars are, the first one is actually to transform health service delivery, where there is an encouragement for public-private partnership. The second point is very important, which is to advance health promotion and prevention. A lot of non-communicable diseases approach is actually based on health prevention and promotion. The third pillar, which is one of the important pillars that support the other 3 pillars, is to ensure sustainable and equitable financing. And the fourth step is actually, the fourth pillar is to strengthen the health system foundation and governance. These are the 4 pillars of the health white paper which has been approved, and the Malaysian government now is moving towards moving into the next stage, which actually to reform the health system through the what is listed down and also outlined by the health white paper. Next slide. The National Health Financing Scheme is a national program normally organized by the government in order to create funding mechanism to pay for various services. The government may then appoint public or private organization to run the program. In the health financing framework, 3 important functions of health financings are to actually collect the revenue, to pool the revenue, and then to purchase the services using various methods, including strategic purchasing, which has recently been given a lot of thoughts and discussions by policymakers. Next slide. The objective of National Health Financing Scheme is to provide regular source of funding specifically focused on health system, to unite various funding sources of healthcare, and also to allocate fair resources from various components of the health services, especially the balance between the preventive and curative services. If we are very serious to address non-communicable diseases, a lot more resources should be allocated for preventive services, which is not the situation that we see in many developing countries. In Malaysia, for example, probably about only 30% of the resources are given for preventive services. The rest are skewed toward curative services. Promote efficient and effective health services and achieve a universal coverage. This is one of the most important aspects. Next slide, please. This is the model of health financing scheme that we are being discussed in Malaysia for the last more than 20 years, but still not put in place. Social health insurance program in the form of mandatory program where the working population in the formal and the informal sector are actually contributing to the scheme, and the focus for the social insurance is to provide services for curative care. Whereas taxation will come in for the poor and unemployed, and the preventive and promotive services will be covered by taxation. Private insurance will play a role where the rich might use this form of financing in order to top up the basic benefit package, which are covered by the mandatory scheme. We also will bring in the direct payment in the form of co-payment to control moral hazards, but we have to be worried about the out-of-pocket expenditure. WHO set a target of out-of-pocket expenditure should not be more than 20% of the total expenditure. This should be kept as one of the important factors that we need to monitor when we implement the national financing scheme. Next slide. For the MPH graduates, when we run health financing scheme, these are the important skills that are normally required. So the graduates have to actually fit into the system that are able for them to be trained in this area. Among the skills are on health economics and financing, of course, health promotion, biostatistics and trend analysis, health planning and evaluation, epidemiology of communicable and non-communicable diseases, health policy analysis, which is an important aspect of the providing the input for the proper policy to be put in place, health and hospital management. There are a lot of job opportunities for the MPH graduates, such as the managers in the social insurance program, health planners. Those who are interested in costing can actually learn more and contribute as a costing expert, benefit package developer, data analyst, expert clinical coders, clinical pathways expert, and also clinical verificators. These are actually some of the job opportunities that might come in once we have a health sector reform in place. Next slide. The facilities such as the financing authority itself, Ministry of Health, private hospitals and clinic, even international agencies will actually have the opportunity for people to come and work with them to support the National Health Financing Scheme. Next slide. So in conclusion, universal health coverage is currently the goals of most of the health system in the world today. We have high burden of non-communicable diseases and lack of sustainable health financing are some of the major obstacles to achieve and maintain universal health coverage. Establishment of the National Health Financing Scheme, mostly based on social health insurance scheme, is one of the main health reform in Malaysia and also in many other countries currently. High demand of MPH graduate with new skill sets in the implementation of National Health Financing Scheme is required in context of health sector reform. These are career opportunities for those who actually come in and join our MPH program for them to work in the National Health Financing Scheme in the future. Next slide. Thank you so much, and I pass it back to Dr. Lin.
Thank you very much, Prof. Aljunid. That was a very insightful presentation. So now I would like to invite both Prof. Hakim and Prof. Aljunid to discuss on the benefit of learning public health and scale up oneself with a master degree in public health. Maybe I will start off with Prof. Hakim. Would you like to start? Or maybe you could share us with your perspective on this and what job opportunities are there for public health degree holders in the United States?
Sure. Can you share my slide? I have one slide.
Okay.
If not, that's okay.
No, yeah, we did not receive.
Yeah. You have not received the slide? Okay, that's fine.
Yes.
Yeah. So I want to reiterate what Dr. Syed said. So with an MPH degree, it is a versatile degree, which means students have a variety of different job career opportunity that range all the way from epidemiology and policy to heading hospital to data analyst to working with community program development, implementation, assessment, all the way to data analysis, and research opportunity. So the degree provide a very wide broad of opportunity. Also, it provide a very wide broad of skills for students that they can gain from having an MPH degree. The job opportunity, at least within the United States, it is in a very high demand. And some of the graduates in some of the field where they work, they make actually 6-figure as their salary. We have some of the discipline that get higher before they end. So as has been, it can range with a lot. So actually it's here. So as you can see, it can range with a lot of different opportunities. And when we talk about, if you want me to address the professional master in public health practice, which is the degree that we are doing joining with IMU. So the benefit, what are the benefits that we always get asked, what is the benefit of a dual degree with University of Arizona? So the first thing is, as we collaborate together, our credit are being exchanged between both universities. So the end result that the student or the graduate will have 2 degrees, 2 separate degrees. One degree is from IMU and the other completely offered from the University of Arizona. And the benefit from the one from University of Arizona, well, the IMU is accredited by the university and the government. The one from Arizona, in addition to be accredited by the university, we are also accredited by the Council on Education and Public Health, which is a top accredited body for professional school of public health, which means that the student with an MPH degree from an accredited school can actually use it, allow mobility worldwide, job opportunity worldwide, but also if student decided to further their education within a PhD or a Doctor of Public Health, they can use the MPH again in any accredited school. They are welcome to come to Arizona, but because it is accredited, they can actually use it not only within the United States, but worldwide as well. So that mobility for people who wanna extend their career within the area, within the region, or beyond globally, it allows them this flexibility with having two degrees and one of them accredited by CEF. It's also a very cost effective because with this agreement with our partner, the cost is maybe around 20% of the real cost, that even not including living and so forth. In the same time, it allows the opportunity for students who want to come for a short visit, do their practicum or internship or interact. They will be welcome to come at no extra tuition fee to spend a couple, 2 or 3 months with their advisor here. In the same time, it allows network and collaboration, both for the student and the faculty, because the student will be working with faculty from both sides, but in the same time, they will be also in the classroom with students from around the globe. So this networking and collaboration is key for developing the next generation of public health practitioners when you work in groups and you get to know what's going on and how to solve problem culturally sensitive across border. And as we can see from the graph, it's covered a lot of different area. And just to put it in context, there is a big need globally with what happened with COVID for trained public health practitioners, whether they are physician or the healthcare professional or even beyond. So our student body and our faculty, they come from different background, and the student pursuing MPH also are coming from different background. I personally did my MPH after I did both my MDs, my medical degree and practice, and my PhD. And when I talk to my student, I tell them when they graduate about all of the different opportunity, and I always add, and you might even be a dean of a school of public health, because I think if somebody told me years ago that what I will do, I will just say you are joking. But it actually does open a lot of open doors. And I work globally with different partners, and I have seen the global movement toward creating public health program, both at the graduate and the undergraduate, to train the next generation that can tackle this global problem without necessarily need to have an MD. So having an MD, I always say with an MPH, wow, it is kind of make us much more community population oriented, looking to the big picture. But it is not really only for healthcare professional. I call it a liberal art degree, that you really, we have engineering taking some of the degrees just to get a concept how they can apply to real practice. So with that, I will stop if Dr. Syed want to add and allow for question.
Very much,
yes,
Prof. Hakim. Yeah. Yes, Dato. Actually, we have one question for you with regards to the job opportunity. So, can I, ask you that first before you add on?
why not? Why not? Yeah.
Okay. So one question is that, is there a job opportunity for, doctors to do MPH in private without health promotion program? Or it was said that it would not be recognized by ministry.
I think this question is regarding the MPH program in private university. I think this dual program actually addressed that issue because the University of Arizona program is recognized, I think, worldwide, and it is a self-accredited. So when they joined our dual program, they'll get both. They get the local flavor by attending the MPH program in IMU, where most of the materials are from the local scenario, which will prepare them to work in the future's health financing, health reform in Malaysia. And at the same time, they will be able to get a degree from the University of Arizona, which is recognized worldwide. And self-accreditation is one of the important sort of people are looking at that for the MPA School of Public Health. And I think this opened up the opportunity, not only working in Malaysia, but also with international agencies. And for those who are interested to work in other countries like the Middle East and all that, I think this MPH degree is very valuable for them. It will actually solve this issue. On the other hand, we know that there is a very limited places for the MPH in the public university at the moment. So if they come to this program, I think they will have a lot of opportunity, which is very highly cost effective, as what Prof. Hakim has mentioned. They don't have to go all the time to US to do this. It is actually an online program. They will spend just a certain appropriate time for them to actually get exposure. I think it will solve a lot of that problem, basically.
Thank you very much, Prof. Syed. So thank you very much to both of you for sharing your opinions on the benefits of learning public health, and also the opportunity not only in Malaysia scenario but also globally, and also in the United States. So let me move on to next agenda Q&A sessions. So before we this is before we invite another speaker. We also have another speaker to provide us with an informative presentations on pursuing Master of Public Health degree at the University of Arizona through IMU credit recognition pathway. So let us look at the Q&A session, Q&As that we have from the audience for the speakers. So maybe I will start with first question. Looks like the first question is for Prof. Hakim. So how can we take part to reduce NCD?
Oh, that's a great question. So how I can address we by two parts. One, we as individual and people, and we as communities and government. So as I mentioned, for example, there are many modifiable risk factors. Tobacco is one of them, alcohol use, and activity. So starting early we do program actually in school. So starting early in school about the importance of health and well-being, about the importance of moving. So starting with health education, training the community health worker, people around to spread the message that prevention is a good intervention. And we are doing, as we train our own undergraduate and MPH student to run this program in school, part of the curriculum about the importance. And so anyone in their Wayne area, make sure that people believe that's working. But in the same time, as communities and public health professionals, in order to reach, and as I said, early detection is key. When behavior is hard to change, you are working on education program, but also you really need to have early detection to control disease. So our way of using this, we have, as a college and a group of students and faculty, we employed like what we call a mobile health units. So we have like vans that are equipped, and students from the different health colleges go together working with public health. So they do screening, very basic screening, like take their blood pressure, their score, and refer, because again, at the bigger level, it is the access to care and the cost of care, as Dr. Syed said, and if they can afford it, if there is no universal coverage, if they don't have insurance. So we refer to them to affordable federally recognized center that afford by sliding, and we have physician volunteer that can help them with that. So you can work at different level. Then as public health professional, policy and advocacy is very important when people can advocate, and that's what make the changes in the year. And take proud of our faculty changing the environment, no smoking at restaurant, no smoking at the building. You can create areas when we encourage people to have walkway, even in the hot area, how to walk. So there is different way, innovatively, that addressing the modifiable and the early detection and management that we can do. While the big picture, which UN, WHO, as Dr. Syed alluded to, it's at least universal coverage, which I hope, I don't know if I will see it in my lifetime, but it will be great. But with the lobby of the health insurance and everything else, that will be a one way, or at least accessibility, and getting the primary health care that could be just as a community health worker that people trust, and spread the message and be able to have the basic training, how to handle just screening and referral and all of the above. So there is a lot that we can do even beyond health education.
Thank you very much. Actually, we have quite a number of questions, but due to time constraint, we are so sorry that we won't be able to address all the questions during the, this live talk. What we can do is we can later, reply to the, attendees, providing the answers for them later, right? So I believe what Prof. Hakim just now addressed cover quite a number of questions already. Maybe I will move on to another questions, which is for Prof. Aljunid. Prof, how will the health white paper address disparities in healthcare access and quality across different regions and demographic groups?
Yeah, this question was asked by one of the participants. I think I mentioned there are 4 pillars in the health white paper. If we study all the 4 items which is listed there, which is called the goals or the targets in the health white paper, issues of access and quality of services from different regions basically is addressed by pillar number 1 and also pillar number 3. The first pillar, which is actually on the changes in delivery of health services. Inside that particular initiative, there are a lot of suggestions for the services to be delivered differently in the future, where there will be a lot of public-private partnership will be encouraged. And Malaysia has been given a lot of priority to the rural population. However, we are still unable to provide probably good access even with that. This is because the Ministry of Health is providing most of the services for both public and urban and rural area. If we have a public-private partnership, those who are staying probably in the urban area would be able to seek healthcare in the private sector. But of course, we need the pillar number 3, which is the health financing. Somebody has to fund for these services. So that's why pillar number 3 on establishing the National Health Financing Scheme would be very important. Whereas those in the rural area, then the Ministry of Health will be able to focus on providing more resources for the health centers and also for smaller facilities where people can access to these services. Even in the rural area, we do have private GPs that are operating. They can also be accessible to the rural population with the health financing scheme providing the resources for them. I think through pillar number 1 and pillar number 3, we would be able to solve a lot of these issues if this is actually being put across in the next activities where there will be a lot of changes in the health system in the future. The plan is that for this to take place within the next 15 to 20 years, it will take some time before this can be realized. I hope that answered the questions here.
Thank you very much, Prof. And so we have one interesting questions, maybe last final questions, maybe for Prof. Hakim. One participant asked, you mentioned that engineers can take NPH, and could you give examples of engineering approach that is applicable to public health?
Yes, definitely. So we do have, as I said, public health is a versatile degree. And they are not only at the NPH, but actually also a lot of them mainly at the undergraduate as well when they take 2 majors, because we do have environmental and occupational health, one health and data science. And many of them take the environmental occupational health because they learn about risk assessment, monitoring, modeling, when you look to infection and asthma. Actually, one of my own faculty who is heading one of the head of the environmental exposure assessment nationally is a system engineer from Stanford, but she is a public health and all her work was on monitoring asthma and modeling. And during COVID, she was instrumental for the entire university by changing all the filter and all of the above. So it became more companies are actually now are interested in hiring doctor of public health. It's kind of a culminating after COVID because they do that. So we do have people who come to do maybe a master, but for the undergraduate level, because the university allow the majors, so many of them combine this and they would like to do data science to get more about the applicability of data within that. And just to add on, as part of the project, we are right now working really closely with the College of Engineering, working on healthcare innovation and device and monitoring those in fall prevention. So it's amazing where the direction and the role of public health in the digital era. And we do have faculty that do AI and public health. So that's why I'm saying it is amazing what you can learn. And even if you focus on an area, what elective that you can sit in and learn as you go. And in addition to the dual degree with IMU, we do actually have dual degree locally. So we have people who do MPH and an MBA, an MPH and a law degree, an MPH and pharmacy locally. The MPH and the MD, which at the graduate level, like here, is very popular in Arizona as well. We have 65 students in our own 2 colleges doing the dual degree for MPH and MDs, which is enriching opportunity for the student. Yeah, it's always people think about what they are doing, and science and math, they do data science as well to try to understand the application beyond just the computer.
Thank you very much, Prof. Hakim. And thank you very much to both Prof. Aljunid and Prof. Hakim for your very thoughtful responses to our questions. So now let me move on to next item. And another exciting moment has come. We have Dr. Gabriela Valdez, Director of Global Education's Global Health Institute, University of Arizona, Melvin Enid Zuckerman College of Public Health, to provide us with an informative presentation on pursuing a Master of Public Health degree at the University of Arizona through IMU credit recognition pathway. So if you have any questions during her presentations, please feel free to type them in our Q&A box, and we are happy to address them after her presentation. So let me hand it over to Dr. Valdez. Dr. Valdez, over to you.
Thank you very much for this opportunity. I'm very excited to be here and talk about this very interesting and exciting strategic partnership that we have with IMU. And we'll be talking about the dual degree program that we have. First of all, I just want to say that this program through the University of Arizona is being offered through the Melvin Enid Zuckerman College of Public Health, where we definitely take pride on educating the next generation of globally minded public health professionals. Next, please. I also want to share some highlights from our college, just to give you an idea of the variety of different interests and research expertise that we have. We definitely have a focus on chronic disease, including diabetes, obesity, cancer. We also focus on health disparities and community-based participatory research, with definitely an expertise in Hispanic and American Indian health. We have a number of projects within our global health research agenda. Because of our proximity with Mexico, we have many different projects within the US-Mexico border, Nepal, China, Kenya, and many other parts of the world. So hopefully we'll be able to share this presentation with you so you can take a look and see all the different highlights that we have here. Next, please. Again, the focus of this presentation is this dual Master's in Public Health degree. It's a collaboration that we have been working for a couple of years now. And what is really interesting about this is that we have evaluated the curriculum from the IMU degree, and many of those courses will be able to transfer to our degree and use to satisfy specific requirements. And then the students will be taking the rest, the remaining courses with us fully online. As Dr. Hakim mentioned, our courses and our programs are fully accredited by CEF. And because of our accreditation, our curriculum is pretty much competency-based. So these are some of the competencies that we expect our graduates to have by the end of our program. As you can see, students will be able to apply accepted financial concepts to analyze the fiscal status of public health, just to give an example here. Next, please. This is a sample plan, study plan. As I mentioned, this is a dual degree. So as part of this degree, it is expected that students will be finishing their IMU degree first before they move on to our U of A degree. So if you are doing this full time, it is expected that during year one, you will be taking IMU courses. And then you transition to year 2, where you start taking the U of A degrees. As you can see here in red, these are some of the courses that you would be taking in semester 1 of year 2. The courses in red are taught by U of A faculty, and they're fully online. Next one, please. This is the second semester course. Now, this is a sample for students who wish to do this fully full-time. So the expectation is that students will be taking anywhere from 4 to maybe 5 classes. But there's also the opportunity to do this part-time. If you're doing this full-time, the plan is for you to finish your IMU degree in year 1 and then finish your U of A degree in year 2. If you want to do this in a part-time basis, we can also explore that. It will probably take maybe double that time. Next, please. And then this sample plan includes the master report or internship. All of our programs are required to have a certain practicum hours. For this one specifically, students are required to complete about 250 hours of practicum, where students actually have the opportunity to apply what they've been learning in their courses to real life scenarios. And we ask for 5 units of that. Next, please. Here are some examples for students interested in this program. This is the duration of the Arizona program. For those students who wish to complete the program full-time, if they want to start in August, which is our fall semester, they can complete their program the following May of the following year. If students who want to do, this is for students who want to complete their internship during the year, during semester 1 and semester 2. Then the second option is for students who maybe want to complete their internship during the following summer. They can start taking courses in August, and then they will complete semester 1, and then they can complete their courses during semester 2. And then at the end, they complete their internship during the summer and during the months of June, July. We also have the option for students who wish to start in March. We have a full-time start in March, where students can start in March of 1 year, and then they will be expected to finish the U of A portion of their courses and their internship the following May as well. And as I mentioned, for those working professionals who are interested in doing this part-time, we can also explore that opportunity as well. Next, please. Some important information to consider is that all the U of A, University of Arizona courses are fully online. Most of our professors work with instructional designers, so the actual content and the actual setup of the courses, even though they're fully online and asynchronous, they are very, very dynamic, and you have the opportunity to interact with other students. As Dr. Hakim mentioned as well, you'll have the opportunity to take these courses with students around the world, either students who might be enrolled in similar dual degree programs, or our students who are taking these programs fully online here on campus as well. And then another important piece of information is that all of our UOA courses follow the University of Arizona academic calendar, which is about, for fall semester, it's tentative start from mid-August to early December. And then for spring semester is from mid-January to early May. Next, please. It's also important to mention that as a student, even though you will be taking your courses fully online, there are some in-person opportunities that you can take advantage of. One of them, for example, is to attend graduation ceremony in person. Here in the picture, we can see a couple of our students from a similar program that we have came all the way to Arizona for graduation this past year. Also, you will have the opportunity, if you wish, to complete your internship and your practicum in Arizona. We just ask that you contact us ahead of time so we can start looking for an opportunity and put you in contact with a faculty advisor who can host you. Next, please. Here are some admission requirements for the University of Arizona portion of the program. We require a bachelor's degree with a 3.0 GPA. We also ask for official transcripts, or in this case, you can also submit 12, you can satisfy this with 12 or more graded units obtained as a graduate student at another institution. So given that as part of this dual degree, you have to be part of the IMU program first, it is expected that you will be able to meet this requirement through that program. We also ask for one course in college biology, one course in college algebra, statistics, or more advanced math. English proficiency for those students who are coming from non-English speaking countries. We also ask for 2 letters of recommendation, a updated resume or CV, a statement of purpose and objectives, and a mission and value statements. And of course, for anyone who's interested, we are more than welcome to provide additional information, especially about the statement of purpose and mission and value statement. We can provide more information about what is expected to be included in those 2 documents. Next, please. Here are some options to satisfy English language proficiency. As I mentioned, this is required for students who are coming from non-English speaking countries. We do require a 90 IBT for TOEFL. We also accept IELTS or PTE Academic Peterson with a 60. I would say definitely the more accessible option that we have is that we also have an in-house test that is offered through the University of Arizona Center for English as a Second Language. And that's the last option that you can see here. You can take it fully online, and that test is about $62. So if you do not need a TOEFL test or any of these other options for other purposes, we recommend taking the CPE full academic test just because it's more accessible than the other ones. Next one, please. Important dates. As I mentioned, students must be admitted in the IMU program first before they apply to this program. And then the next deadline, if you would like to start this August, it will be June 1st is the next application deadline. And for those students interested in starting in March of next year, the next deadline would be November 1st. Next, I think this is all. I will be happy to share my contact information in the chat in case you have any questions. Feel free to reach out directly, and we will be happy to answer any questions, set up a Zoom meeting if you'd like to chat about the benefits of this program. Thank you very much.
Thank you very much, Dr. Valdez. And I think this question is for you. Audience asked Dr. Gabriela for IMU public health students who missed the valuable opportunity to apply do this dual degree program. What can we do to, upgrade?
Students who have completed their IMU program, they can still apply for this program if they're interested. Even if they have completed this program a year, maybe 2 years ago, they can still do it. The important thing is that since we are using some of the IMU credits to satisfy some of our requirements, it is important that students take and have completed those credits before they take. We, aside from this, we also have a number of fully online graduate certificates as well on different areas. That's something else that we can explore. But definitely, if you're interested, please reach out, because there might be different ways that you can still engage in this program.
Okay, thank you very much. Okay, another questions. How does the joint Master in Public Health program between University of Arizona and IMU offers a unique and comprehensive curriculum that combines global perspective with local health challenges?
I think Dr. Syed highlighted this in the previous presentation, where I really believe that students will be getting both the best of both worlds, right? Where they will receive the training, great training from IMU, and really contextualize the information and the needs of their population within Malaysia. But also you will be getting a real life example of not only the United States, but we have very global minded faculty members that include examples from all over the world. So I think perspective would be one of them, being able to work and be in classes with students from all over the world. That also is such a great opportunity, because it enriches discussions in the classroom. You are able to learn from your peers and learn from the different public health needs that their communities might have. So I think it's a real global exposure for students who are interested, and not only learning from a global setting, but also acquiring the skills that you need as a public health professional, where you have to make sure that whatever public health implementation or interventions that you have that are culturally relevant, and that you're making sure that you are fully understanding the needs of the communities that you're working with. And I think that's definitely some of the strengths that you will get from this dual degree program.
Definitely. Thank you very much, Dr. Valdez. So I believe we are, exceed the, time already. It's 9:50 local time. So we are going to end the sessions here. For the remaining questions, we will reply to you. And for the talk, we recorded the session, so we will be posted it on the IMU YouTube channel. So we will inform to the participants when we can make this available on the YouTube channel, and you can access and watch the videos again especially on the Prof. Hakim presentations, and Prof. Syed, and also Dr. Valdez presentations. So ladies and gentlemen, as we come to the end of our webinar, I would like to extend our heartfelt thanks to Prof. Hakim and Prof. Syed, Prof. Junid for sharing the expertise, and Dr. Valdez for the informative presentation with us today, and all the organizing team members for the live talk today. And a big thank you to all of you for attending and participating in these live sessions, and we hope you find it very valuable and informative. So ladies and gentlemen, please keep an eye on our website, social media channels for information about upcoming webinar and events. And if you have any questions, please visit our website at imu.edu.my@pt. So everyone, have a great day ahead, and we look forward to seeing you at our next live talk series. Goodbye, everyone.